Hi, and welcome to RadOnc Talks, a lecture series designed for students and residents of radiation oncology. My name is Ria. I'm currently a PGY4 at the University of Pittsburgh, and today I will be taking you through our next segment of the RadOnc Emergency/Palliative series with a talk on bone metastases. If you already watched the cord compression lectures, you already know what's up. Hopefully we'll be able to fit all of this in just one talk, though. We'll start with the epidemiology, workup, and prognostication, and then get into classification and management of bone mets. As you may already know, bone is one of the most common sites of metastasis for cancer. It's often the first site of metastasis that we detect. The top 5 cancers that metastasize to the bone include prostate, breast, renal cell, thyroid, and lung cancer. Keep in mind that bone metastases can be osteolytic, osteoblastic, or mixed. Prostate and breast cancers are the two that are often thought of as being osteoblastic lesions, but sometimes they can also be mixed. Bone metastases, when they're symptomatic, most commonly present with pain, but keep in mind that they can often just be detected on staging imaging. Let's talk a little bit more about their workup and prognostication. So as always, we start with a full history and physical. You want to assess the patient's pain, if they have any sensory or motor dysfunction, perform a full, physical exam, examine their walking ability, and keep in mind, is the lesion involving any weight-bearing bones? Are we concerned about an impending fracture risk? These are important things to kind of note during your H&P. In terms of imaging, an X-ray scan is certainly doable, and it's often good for things involving the appendicular skeleton, but CT scan is definitely more sensitive. Remember, if there's any concern for spinal cord compression, we're always going to get an MRI with and without contrast, preferably of the full spine. And we may also utilize bone scintigraphy, and this is often utilized in staging for things like breast and prostate cancer. Now, if we're dealing with a solitary bone tumor, or if it's a new bone tumor without an existing cancer diagnosis, or if it's the first site of patient's metastatic relapse, we always want to confirm what we're dealing with by obtaining a tissue diagnosis. So this can be done by either CT-guided FNA or core biopsy, which is preferred. And remember, depending on where the bone tumor is located, you always want to have the appropriate consultants on board. So orthopedic surgery, if it's a weight-bearing bone and you're concerned for fracture, neurosurgery, if there's any concern for cord compression or skull metastasis. When I first started residency, I actually had a hard time seeing bone metastases a lot of the time on CT scans. And so I just wanted to show you some examples. This is an example of mixed lytic and sclerotic metastases in a patient with breast cancer. Lytic lesions will typically appear loosened, so kind of the same density as soft tissue on a CT scan. They will appear darker or hypodense, as we say when we're talking about a CT scan. Sclerotic lesions, on the other hand, will appear hyperdense or whiter on the CT scan, as you see in the sacral bone pictured on the right. In terms of prognostication in patients with bone metastases, Dr. Chow and team published a predictive model for survival in metastatic cancer patients, which was published in 2008. And they identified 3 risk factors that correlated with poorer overall survival. So these were having a primary that was non-breast cancer, having presence of non-bony metastases, and having a performance status, a Karnofsky performance status of 60% or less. So with just 0 to 1 risk factors, the predicted median survival was 60 weeks, and with 3 risk factors, it was low at 10 weeks. A more modern prognostic system came out from Japan in 2019. This is called the Katagiri scoring system, and it's a 10-point scoring system that utilizes 6 parameters and helps to predict overall survival in patients with bone metastases. This was based on retrospective data from 600 some patients treated at their institution, and the parameters include, number 1, the primary characteristic of the tumor itself. So is it slow, moderate, or rapidly progressive? And they had definitions of tumors. So breast and prostate are examples of slowly progressive tumors. Lung, head and neck, cervical cancers are examples of rapidly progressive tumors. So, 0, 2, or 3 points, depending on that. The next parameter was visceral metastases, if they were present and were they nodular or disseminated. Labs, were they normal, abnormal, or critical. The ECOG performance status, whether or not they've had prior chemotherapy, and whether or not they have multiple skeletal metastases present. So this scoring system gives you a score from 0 to 10. 0 to 3 is low risk and corresponds to a median overall survival of 27 months, whereas 7 to 10 is high risk and corresponds to a median overall survival of 2 months. And so, all of these prognostic systems are quite useful, and you can certainly plug and chug these numbers if you're interested in doing so. But I really think the key takeaway is that we get a lot of information about our patients just by looking at them. If they have a good performance status, if they're walking, talking, working, doing all their activities of normal living, that is a good prognostic sign. But if they're bedridden, if they're not able to get dressed in the morning, if they need help doing most things, that is a poor prognostic sign. So a lot of the information about these predictive models you can just get from looking at the patient and from their chart review. And, the whole point of this is that we don't want to subject our patients to more than they can tolerate. And we also don't want to do things that are excessively invasive and things that will, not promote their quality of life and maybe just subject them to more unnecessary treatments. And that's really the goal of these prognostic schemes. So we've talked a lot about evaluating these patients now, and we understand that it's really important to look at the patient themselves and also to consider the biology of their disease. Obviously, a bone met from breast cancer is going to behave a lot differently compared to a bone met from lung cancer. So it's really important to holistically consider the patient, consider their systemic disease biology, the extent of it. But there are ways to classify bone mets just based on the appearance of the bone met. So let's talk a little bit about that. The simplest way to classify bone metastases is by using the terms complicated versus uncomplicated. So what does that mean? Uncomplicated bone metastases are typically defined as painful bone metastases that are not associated with impending or existing pathologic fracture, and those that are not associated with existing spinal cord or cauda equina compression. So if you're concerned about a pathologic fracture, or if you see that there is cord or cauda compression, that is considered complicated. The reason it's important to classify bone metastases is because it helps orthopedic surgeons determine if there's a need for prophylactic fixation. So Harrington's criteria were proposed historically, however, they have not been validated. I've just kind of kept them here for reference for you, but what we would probably use in the modern era is something called Morell's criteria. So nothing is perfect, and Morell's criteria have been accused of slightly overestimating the risk of fracture, but I still think it's a useful scoring system and good for you to know. So in Morell's scoring system, we really take into account 4 different aspects of a bone metastasis. So the site of the lesion, the size of the lesion, meaning how much of the cortex is involved, the nature of the lesion, if it's blastic, mixed, or lytic, and finally the pain. Is it mild, moderate, or functional? So as you can see, there's a table, and each of these 4 parameters correspond to scores. You end up adding all the scores together, and a score of 7 or less on Morell's scoring system, the recommendation is radiation and observation. A score of 8 says to use clinical judgment, and a score of 9 or above, the recommendation is prophylactic fixation. So again, not perfect, but definitely a good reference for you to know, site, size of the lesion, nature of the lesion, and if it's associated with pain. So now that we've discussed kind of holistically approaching the patient and then individually approaching the features of the bone metastasis itself, let's move on and talk about management. The treatment options for bone metastases are really, very comprehensive in terms of treatment options for cancer in general. So you have your regular surgery, radiation, chemotherapy, may or may not utilize things like bone modifying agents or unsealed sources. And finally, pain management, oftentimes in conjunction with a palliative care consultation using medications like Tylenol, NSAIDs, narcotics, is going to be critical. Most patients with metastatic cancer utilize some medley of all of these things to achieve stability. In terms of surgical options for treating bone metastases, for the spine, we talked about a lot of different surgical approaches in our lecture on cord compression. Remember, we talked about decompression, laminectomy, as well as corpectomy. Now, in terms of spine mets, there are often lesions that don't cause cord compression, but they still cause vertebral collapse and things like that. And so I just want to take a moment to go over some additional interventions that surgeons can do. So one of them is vertebroplasty. So if you have a lesion in the body of the vertebra, for example, that causes collapse, with the vertebroplasty, they can inject some cement into that collapsed area with the idea of filling in the defect and making it more robust. If the vertebra is very severely collapsed, they may first need to kind of inflate the area using a balloon device. So this procedure is known as a kyphoplasty, where they actually create a cavity in the fractured vertebral body by percutaneously placing a balloon device. And then once they inflate it and kind of create the cavity, they can take out the balloon and inject the cement into the cavity. So that's a little bit different than vertebroplasty because first we have to build up that cavity. So this is called a kyphoplasty. Switching gears now, another very common site of fracture in the setting of bone metastases is any of our weight-bearing bones. So this includes our hip and our femur. And oftentimes we see subtrochanteric fractures, as in this photo, and the surgeons need to place an intramedullary rod for long bone stability and sometimes do some cementing. Just as radiation provides a benefit after spinal decompression and cord compression, it turns out that radiation following orthopedic stabilization also shows a benefit. An early trial showing this benefit was actually a retrospective review of patients treated with orthopedic stabilization, and they evaluated multiple potential prognostic factors that could feed into the patient's functional status. But on multivariate analysis, it turned out that receiving post-op radiation was the only significant factor associated with good functional status after surgery. So most patients in this trial received radiation to a median dose of 30 gray within 6 weeks of surgery, and most of them had the entire length of their hardware treated. After radiation, the estimated probability of achieving normal use of that extremity was 53% if the patients received radiation versus just 12% if they received surgery alone. Receiving that post-op radiation also decreased the need for a second surgery at the site of the first surgery. And I think this makes sense, right? If a patient has a fracture because there's cancer growing in that area and an orthopedic surgeon goes and places a rod, they're not really getting rid of the cancer in that region, they're just stabilizing the bone itself. If we follow that surgery by adding some dose of radiation in that area to help provide some local control, then we can help prevent the cancer from progressing there and kind of help maintain the benefits of that surgery. So we just mentioned in that retrospective analysis that we discussed that most of the patients had the entire length of their hardware covered in the postoperative radiation field. And this practice is further corroborated by a retrospective analysis that came out more recently from Memorial Sloan Kettering. And the median dose that patients were treated to was 30 gray. Again, this was a retrospective analysis, but their analysis showed that covering the entire length of the hardware was associated with a decreased risk of local recurrence. And so that really should be the practice when possible, to cover the entire length of the hardware. We have here some additional retrospective data supporting coverage of the entire hardware. One retrospective study out of Harvard and another study that applies specifically to patients with multiple myeloma. Again, the extent of hardware coverage predicted disease relapse along the hardware. So if a patient gets orthopedic fixation, make sure that you try to cover the entire length of the hardware. While we're on the subject of multiple myeloma, I just wanted to mention that myeloma represents kind of a unique histology. This particular study was a retrospective review published in 2020, and they showed that regardless of the BED or the biologic effective dose, whether it was less than 28 gray or greater than 28 gray, most patients had pretty similar rates of re-irradiation. The only place where we saw a significant difference was when patients had spinal deposits with a Bilski score of 3, so high grade cord compression. And so I think the takeaway from this, and the ILROG guidelines reflect this as well. So for multiple myelomas, when you're treating, they can usually tolerate lower doses like 8 gray in 1, 20 gray in 5. I've often seen 24 gray in 8 fractions. Doses such as 30 gray and 10 fractions should really be reserved for bulkier masses or things that are causing high-grade cord compression when you're really hoping for durable control. Okay, so we've established now that if a patient is getting surgery, there is a benefit to post-op radiation. If there's hardware placed, we want to cover the entire length of the hardware. Let's talk now about some trials looking into the different fractionation regimens for palliative radiation to bone metastases. The earliest trial I want to mention is RTOG 7402. And if you don't know this already, RTOG trials are named so that the first 2 digits in the name correspond to the year that the protocol was written. So RTOG 7402 is a very old study, right? Protocol written in the year 74, was published in the 80s. But this was a randomized trial that compared different fractionation regimens in patients with bony metastases. So they looked at 40 gray and 15, 30 gray and 10, 15 and 5, 20 and 5, and 25 and 5. And they actually found that there was no difference in the regimens in terms of the relief or how quickly patients experienced relief. They did perform a reanalysis, which showed that a higher number of fractions corresponded to greater rates of complete pain relief. But keep in mind that this was physician assessed and not patient reported. So again, old study, it's going to have its flaws and not totally applicable in the modern era. But this is our earliest evidence that there's no significant difference in the different fractionation schemes used in terms of symptom control. So already we're starting to see what we saw with all those cord compression studies that we talked about, where short course versus long course provides equivalent symptom control. A more recently published study, which this is a meta-analysis now of 29 randomized trials comparing single fraction to multi-fraction regimens for bone metastases, and they found that there was no difference in terms of pain relief or toxicities when comparing single fraction to multi-fraction radiation regimens. On average, so upwards of 60% of patients had an overall response, so some response, and 23 to 24% of patients actually had a complete response. So I think that these numbers are more similar to what I would usually quote to patients in terms of what they can expect from palliative radiation. Another thing to keep in mind from this meta-analysis is that they did see that retreatment was more common in patients who were treated with a single fraction. So again, the results of this meta-analysis kind of mirror the results from the RADIES trials that we talked about in the cord compression lecture. So shorter course or single fraction radiation provides equal pain relief, equal symptom control. However, the longer fractionation tends to be more durable in control. One of the randomized trials that I'll just take a moment to highlight is RTOG 9714. Again, not one of the newest trials, but a significant one. It compared 8 gray and 1 fraction to 30 gray and 10 fractions for patients with 1 to 3 painful bony metastases. And again, they found that both regimens were equal in terms of pain relief and narcotic use at 3 months. They were generally well tolerated. The 30 gray and 10 arm did have a slightly higher rate of acute toxicity that was significantly different, so 17% versus 10% grade 2 or more acute toxicity. However, the 8 gray times 1 arm had higher rates of retreatment compared to 30 and 10, so almost double, right? 18% versus 9% retreatment with 8 gray times 1. So again, the same exact thing. We see the pattern again and again. the short course radiation is equivalent in terms of symptom control, but the longer course radiation does provide more durable control. So up until now, we have been talking about radiation for symptomatic lesions, right? Things that present with pain, things that cause cord compression, things that have been interfered with operatively. However, there was a study that came out in 2022, published by Dr. Gillespie and actually presented at ASTRO 2022, which was a phase 2 randomized controlled trial of prophylactic radiation versus standard of care in high-risk asymptomatic bone metastases. So in this phase 2 randomized trial, they included patients with high-risk bony metastases. And high risk was defined as anything bulky or greater than 2 centimeters in longest dimension, anything involving the junctional spine or posterior spinal elements, anything involving the hip or sacroiliac joint, and anything involving the long bone with 1/3 to 2/3 cortical thickness. They randomized these patients to receive either prophylactic palliative radiation or just whatever they would as standard of care, instead of getting any radiation. And the primary outcome was a skeletal related event, which was defined as fracture, cord compression, or intervention with surgery or radiation. They found that a skeletal related event occurred in almost 30% of patients treated on the standard of care arm versus less than 2% of patients treated on the prophylactic radiation arm, and that was statistically significant. So it turns out that prophylactic radiation in these high-risk patients actually improves their time to skeletal-related event, it decreases their rate of hospitalization, improves their pain, and it actually improved their overall survival too. So this was kind of a small randomized phase 2 study, but I think the results are still very significant, and we should definitely be considering prophylactic radiation in patients with high-risk bone lesions. So oftentimes after we treat with radiation, several months later, we find that patients return to us with, worsening pain again in these previously treated bony metastases. RTOG 0433 was a randomized trial looking at 8 gray in 1 versus 20 gray in 5 to 8 fractions in the setting of re-irradiation for painful bone metastases. And they actually found that there was no significant difference in the regimens in terms of overall response rate. However, the single fraction treatment regimen turned out to be less toxic, less vomiting, diarrhea, skin redness, and so on. And so again, anytime you're doing re-irradiation for these palliative cases, you always want to make sure you're creating planned sums with your prior plan. Make sure you're not exceeding normal dose tolerances for very important structures such as the bowel or the spinal cord. Make sure you're looking at your Quantec dose constraints and then also converting in EQD2 to make sure that you're correctly estimating what you're treating the spinal cord or whatever organ to. But so re-irradiation is safe, and there's data now that a single fraction is equally effective with less toxicity. When you counsel patients about toxicity relating to bone met radiation, obviously you want to include relevant toxicities to the anatomic location that you're treating. So if it's something in the neck, maybe pain with swallowing. If it's close to the abdomen, they might have some nausea. One of the unique toxicities for treating bone metastases is a phenomenon known as pain flare, which is really a temporary worsening of bone pain in a treated metastatic site. I kind of describe it to patients as swelling and kind of a reactive pain from the cancer cells breaking down in the area that is treated. If it happens, it usually happens in the days or weeks following radiation. And I usually tell patients that after radiation for a bony met, the pain might get worse before it gets better. There have been some studies investigating dexamethasone for prophylaxis to kind of reduce that swelling within the bone. And there have been some literature reviews, but still there was kind of a lack of consensus on exactly how to use the steroids. There was a randomized trial called the Dutch DEXA study published in 2020 where they randomized patients to receive either steroids or placebo before and kind of during the first few days of radiation. And it turned out that the incidence of pain flare between these three groups was not truly significantly different. If you look at the curves, it just appeared that dexamethasone kind of postponed the pain flare, but it did not really prevent it from happening. And so, based on these results, I don't think that dexamethasone has any clear role in prophylaxis of pain flare. I have never seen it used prophylactically unless it's in the context of stereotactic radiation. What I would generally recommend is pain flare is generally, certainly something to be aware of. I always counsel patients about this. It might occur a few days following radiation, and if they notice that the pain is getting worse, they should call the office. At that point, when they are experiencing pain flare, we would typically use steroids to treat this, something like 2 to 4 milligrams daily for a few days and see if that helps. Not too much steroid, but if they happen to have it, we can certainly treat with steroid, but typically not in the prophylactic setting. So we are nearing the end here, but there's a few additional treatments that I just wanted to mention to kind of complete our discussion on bone metastases. Bone modifying agents are drugs that would typically be prescribed by the medical oncologist, but they include bisphosphonates such as pamidronate or zoledronate, which inhibit osteoclasts, and they're associated with side effects such as osteonecrosis of the jaw and atypical femur fractures. Another class is the rank L inhibitors such as denosumab or brand name Xgeva, which can prevent osteoclast maturation. Something that we would probably use more frequently in the rad-onc department is these radiopharmaceuticals. And it's important to be familiar with them because, we're often tested on these and we actually treat patients with these. I won't go into too much detail for the sake of this particular talk, but just to be aware, some examples of radiopharmaceuticals include phosphorus, which has a very high hematologic toxicity, so it's rarely used. Strontium and samarium, which are both beta emitters. Strontium is a pure beta emitter. Think strontium or strong for pure beta emitter. Samarium is primarily beta, but has a component of gamma emission as well. So I think samarium, somewhat gamma. Strontium and samarium both cause severe myelosuppression. So that is a side effect to know. And then finally, we have radium-223, which is Xofigo. This is an alpha emitter. Again, we use this only if patients do not have myelosuppression, so we need to check their blood counts every time we inject Xofigo. The data for Xofigo is based off something called the Alsimca trial, which looked at patients with metastatic castrate-resistant prostate cancer, and it turned out that using Xofigo actually provided an overall survival benefit, and it improved time to their first symptomatic skeletal event. So Xofigo is very commonly used. Another newer one is lutetium-177 or Pluvicto. So again, just be familiar with these unsealed sources, and someday in a different talk, we'll go into further detail about them. Just to kind of draw all of our knowledge to a close here, I wanted to end with the ASTRO guideline on palliative radiation for bone metastases. This is based on the 2017 update. So in this guideline, it states clearly that, following single fraction or multifraction up to 10 fractions, there is equivalent pain relief in previously unirradiated bone metastases. We know that single fraction radiation is associated with higher rates of retreatment, so more prolonged fractionation schemes tend to provide more durable control. But single fraction is most convenient, especially for patients with limited life expectancy, and there's no evidence that it's associated with higher rates of pathologic fracture or late toxicity. In terms of re-irradiation, the guidelines recommend offering retreatment at least 1 month following external beam radiation if patients have persistent or recurrent pain. Obviously, in the setting of re-irradiation, you want to be very careful about your normal tissue dose constraints. In terms of, counseling patients, oftentimes we will get phone calls just a week or two after radiation, and patients will say they don't actually feel much improvement. I would advise them to wait at least a few weeks and follow up with them a month after treatment, because it can take some time for the effects of radiation to kick in. And then finally, note that these guidelines state surgery, radionuclides, bisphosphonates, none of this obviates the need for external beam radiation. So that means all of these patients, after receiving other types of treatment, are still candidates for external beam radiation. Just in case you'd like a TLDR, like a too long, didn't read, here's just a conclusion slide for your reference. And that is all I have for bone metastases. Thank you so much.